The Sydney North Health Network wishes to acknowledge Australia's Aboriginal peoples, the traditional custodians of the land on which we meet and work. We pay our respects and recognize their continued connection to land, water, and community, and honor their ancestors, elders past, present, and emerging. And we extend that welcome to anyone present with us this evening.
Okay, so this is a really bit of an intense topic as well. And it's really about taking a risk-based approach to the management of the primary healthcare practice. So I have got some learning outcomes for you, and it's really about understanding what are the factors that contribute to the environmental transmission of pathogens, to explain how airflow and air exchanges help reduce the transmission of respiratory viruses, but also other pathogens as well. And then we will discuss how to perform aerosol generating procedures, and we'll finish up talking about environmental cleaning. So a little bit of background first. Certainly the healthcare environment contains a diverse population of microorganisms, but only a few are significant pathogens to susceptible hosts. We know that microorganisms are present in greater numbers in moist environments and organic environments, but some can also persist under dry conditions. So although pathogenic microorganisms can be detected in air and water and also on fomites, so non-living surfaces, assessing their role in causing infection and disease is actually quite difficult. So having an understanding of how infection occurs after exposure based on the principles of the chain of transmission, which we've talked about in both of the past webinars, it's important to assist us in evaluating the contribution of the environment to healthcare-associated infection. So all of the components of the chain must be operational for infection or colonisation or carriage to occur. So that means that we need an adequate number of pathogenic organisms. So that's what we refer to often as the dose. The pathogenic organisms also need to be of sufficient virulence to survive and to cause infection or colonisation. We need a susceptible host, an appropriate mode of transmission or the transferal of the organism in sufficient number from the source to the host. And we also need a correct portal of entry into that host. So with that in mind, we'll start off with talking about ventilation. Now, I need to preface this by stating that I'm not a ventilation expert. So the process of supplying or removing air by natural or mechanical means to or from a space is really what ventilation is. It's important in all sorts of different healthcare settings, as what it does is it improves the indoor quality by reducing the number of particles in the air. So those particles might consist of microorganisms, such as bacteria, virus, and molds or fungi, dust, pollen, and also those volatile organic compounds, which we commonly refer to as VOCs. So good ventilation aims to reduce potential exposure to respiratory viruses or respiratory particles, I should say, containing infectious agents. So that might be COVID-19, influenza, pulmonary tuberculosis, chickenpox, and influenza. And also what good ventilation does is it increases staff and patient comfort. Poor ventilation, we know, can lead to drowsiness and poor concentration, headaches, dizziness, shortness of breath, coughing and sneezing, hypersensitivities and allergies, or dry or irritated throats, eyes, nose, or the skin as well. So just a little bit about airborne infectious diseases. So there are a variety of airborne infections in susceptible hosts, and they can result from exposure to clinically significant pathogens that get released into the air when the environmental reservoirs are disturbed. So we would consider an environmental reservoir being soil, water, dust, and also decaying organic matter. So once those materials are actually brought indoors into your practice by any number of vehicles, that could be people, it might be air currents, it might be water, perhaps construction materials, and equipment. So, for instance, those external transport corrugated cardboard boxes that your consumables often come into, so the outer container can actually be quite contaminated. So once they come indoors, then the microorganisms can actually proliferate in various ecological niches within your practice. And if they're then subsequently disturbed into the air, they can serve as a source of healthcare-associated infections. So we'll start off by looking at the fungi or the molds. So because this is not just related to respiratory viruses. So Aspergillus species are what we call ubiquitous in the environment. They're naturally occurring there, and they're an aerobic fungi. They occur in soil and water and also decaying vegetation. And the organism survives very well in the air, but also in dust, and if there's any moisture present within your practice building. So we know that the presence of Aspergillus species in a healthcare facility is a substantial extrinsic risk factor, particularly for those patients who are very immunosuppressed and may be at risk of invasive aspergillosis. So improperly functioning ventilation systems, such as air filters, your air filter frames, window air conditioners, false ceilings, any fireproofing material that you may have, damp wood materials, or even ornamental plants, can all actually be nice reservoirs for these organisms. And then if we have patient care items or devices or equipment that actually becomes contaminated from these fungi or mold spores, they can actually then serve as a source of infection if those items are stored in such areas. And we do see in some environments, particularly in hospitals, where there's increased levels of associated clusters of healthcare-associated infection, particularly, as I said, in those immunocompromised patients. So we really need to be thinking about our environment. And I've just put some pictures that my team have taken when we've gone into practices to undertake infection prevention and control audits. So it's it's quite scary. We can see non-porous surfaces, we can see wet surfaces, and we can certainly see mold growing. And we can see opportunities for these fungi or mold to actually enter into the building because we've got non-intact surfaces there. Now, viruses and bacteria. So we know that these can be transmitted certainly through respiratory droplets, but also aerosols, and to a lesser extent through direct physical contact or indirect contact with contaminated fomites and surfaces. So there are numerous reports of healthcare facilities where there's been Aspergillus species, Mycobacterium tuberculosis, measles, and varicella zoster viral transmission. And to a lesser extent, there's been reports, and you'll be familiar with them, around respiratory viruses such as RSV, adenovirus, COVID, influenza, and also norovirus as well. So what happens is that we produce these respiratory particles, whether they be droplets or aerosols, during our expiration activities. So that might be coughing or sneezing, even talking, stinging, shouting, and vomiting as well. And so these viruses are often small enough to actually remain viable within the environment, and they tend to float because they're light, and they can actually travel quite large distances on airflows, in particular the aerosols. So if we have poorly ventilated spaces, then they can accumulate, and then if we have at-risk patients or even staff, those aerosols can actually be inhaled, both at short and long ranges. So this slide probably demonstrates that. So what we can actually see is both aerosols and also droplets. So the larger particles are the droplets and the smaller ones are the fine aerosols. And when we look at these aerosols, which generally tend to come from the lower respiratory tract in the bronchioles, when they're actually coughed out or sneezed out or some sort of other expiratory activity, because they're light and they can float, they go a lot further. So they can go beyond the traditional 1 to 2 meters that we talk around. And therefore, they can be inhaled. Up to 100 micrometers can actually be inhaled. When we look at the droplets, they tend to, because they're heavier, they tend to fall to the ground, and quite quickly because they're heavy, or maybe they'll fall onto a surface, whether that be an environmental surface or in fact a fomite that's on that surface. These tend not to be inhaled, but because they fall onto a fomite, or unless it's the respiratory tract and you're within 1 meter of that infected person, the susceptible host is, they might be well picked up from the surface, from the fomite, with your hands, and then you touch your face or your eyes or your nose, and we can have transmission occurring that way. So there's quite robust evidence supporting the airborne particle transmission, both from fungi and molds, but also bacteria, as we talked about with pulmonary tuberculosis, and the other viruses such as RSV, flu, and some of the human coronaviruses as well. So when we look at the over here on the right-hand side, what we can actually see is virus-laden aerosols, and they have particular characteristics which can assist with the transmission of these infections. And so a lot of that's around size, how much, the viral load, how infectious the particle or the aerosols are, but also other chemical components such as electrolytes, proteins, and surfactants, their pH value, and their electrical charge all can actually influence the risk of transmission of infection. If we look at this diagram, what this is actually showing is the phases involved in airborne transmission. Now, I don't want to sort of laden you down with too much science, but I think it's quite interesting to get a really good understanding of what the dynamics are. So these, the airborne transmission of these virus-laden aerosols includes generation and exhalation. It also includes transport, and then the third phase is around inhalation, deposition, and infection. And so there can be a number of factors that might actually interfere or decrease or increase the risk for transmission. And there'll be things around relative humidity, temperature, the airflow, the ventilation system, the activity that's actually being undergone within that environment, and any, I suppose, attributes that you might have in terms of supplementing your ventilation systems as well. So it's quite interesting to see, transmission's not always guaranteed. There's a whole load of factors there, environmental factors that can contribute. So what is the purpose of ventilation? It's about maintaining indoor air temperature and humidity. It's about controlling odours, removing any contaminated air, facilitating the air handling requirements so that you are protecting your susceptible patients, but also staff. And it's about minimising the risk of transmission of airborne pathogens from infected patients. So let's actually have a look at what the types of ventilation are. So initially, if we look at natural ventilation, so what natural ventilation does is it actually introduces outdoor air through windows or doors or maybe other openings. And it encourages the removal of that indoor air through maybe an open door again or a window. So natural ventilation, in particular in healthcare facilities, is probably alone not going to provide you with good air. Now, you all come from different practices. Some of you are standalone practices, others are part of buildings where it's probably really difficult for you to actually be able to control the ventilation. And so in that situation, most of you will probably have what we refer to as mechanical ventilation, and that can be divided up into HVAC and also split systems. So when we look at mechanical, an HVAC, so heating, ventilation and air conditioning system, includes an outside air inlet, so or intake, so we can see that here on this diagram of the building. It includes filters, humidity modification mechanisms. So in summer, we have humidity control. In winter, we have humidification. It also consists of heating and cooling equipment, fans, ductwork, and an exhaust air outtake as well. And then in addition, you can have items such as registers and diffusers and grills, and that's all to ensure that we have proper air distribution. So if we look at the HVAC system here, we can see that the air is coming in, and we want the air to come in because we want it to dilute the stale air within your practice environment. It goes through some sort of air filtration system, and then it comes into the building. And then it gets distributed and then back out through the system, and the contaminated air is released through the exhaust or through the outtake. Split systems tend to recirculate air within a space, and they ideally should be avoided in patient care areas, and particularly in areas where you may have patients who require airborne transmission precautions, or you're doing aerosol generating procedures. There is a hybrid ventilation system. So this is using a combination of mechanical, so quite often that split system, as well as natural ventilation. And then in addition to this, we have what we refer to as our augmented ventilation. So these are when we use supplementary devices to improve the natural or the mechanical ventilation. And that's about reducing those aerosolized viral particles so that we're improving that air circulation and the distribution. So this might be, a portable air cleaner or scrubber with HEPA filters. It might be a air filtration system within your HVAC system, or it might be a UV disinfection system in the upper areas of your building if you're on more than one level. We do know that if we have decreased performance of our healthcare, particularly our HVAC systems, and that might be due to filter inefficiencies, improper installation, or simply poor maintenance, all of those can actually contribute to the spread of healthcare-associated infections. Now, there are lots of published guidelines for the design and the construction of new premises or for the renovation of existing premises. So, we look at the Australian Building Code, we look at the Australasian Health Facility Guidelines, Australian Standard 1688, which we referred to last week, and also AS 5369 around reprocessing, and we'll revisit some of that this evening. So they address the indoor quality standards. So that's around ventilation rates, our temperature levels, our humidity levels, pressure relationships, and also the minimum air changes per hour to specific zones or areas within your practice. So we referred to sterile storage areas last week. We referred to dirty utility areas, to reprocessing areas where you're cleaning. And I'll explain the air changes in a bit more detail shortly. But we do, as I referred to, have these emerging technologies. So it's really important that we assess our current ventilation. So I think through COVID, we were all encouraged to undertake a ventilation assessment. And that also helps you to see if your system, whatever system you've got, natural or mechanical, is actually working correctly. But it actually also allows you to determine if you need for additional or augmented ventilation as well. And that's always best undertaken by a professional. So whether that's a HVAC engineer consultant, or whether it's a environmental hygienist, occupational hygienist. So you can just see the ones that I alluded to before. So our air filtration devices and our air scrubbers. In our hospitals, we've seen the personal ventilation hoods either over the bed or over the upper body of the patient, particularly for things like viral hemorrhagic or with COVID too. We certainly saw that. And of course, this ultraviolet germicidal irradiation. So I think it's really important to keep abreast of what's in the literature. And, if you find that through your assessment that there is a need, that you're having some impact on your airflows and also work health and safety requirements, then there may be some additional ventilation methods that you can supplement or augment your existing system with. And then, of course, making sure that we develop protocols around that, particularly if you're using air scrubbers. You know, air scrubbers, if you've got a good ventilation system, air scrubbers can actual fact be not so good. So if we're going to use them, then we need to have pretty strict protocols about how they're set up, where they're located, and how they're maintained. So some of the ventilation requirements, and I'm not going to go into all of them, but I do think that in particular where you have areas where you've got maybe confirmed positive patients with some of these organisms that we've been talking about, then the air should be actively ducted to the atmosphere outside of the practice building. So, you know, we don't want it staying within the building and increasing the risk. The supply of the outdoor air through the HVAC system should probably be increased as reasonably possible within areas of the practice building. So like where you're likely to have to put into place transmission-based precautions or where you're undertaking those aerosol-generating procedures. We still have to maintain the normal indoor temperature and humidity set points, you know, purely for comfort. So with our relative humidity, we try and look at sort of 40 to 50% for that to be appropriate. And then we need to look at our air changes as well. So the current recommendation for standard rooms in hospitals is to have at least 6 air changes. Now, if you can achieve 4 or 5, if you're not able to get to 6, but you can achieve 4 or 5, then, you know, then that's pretty good. So it is really important that we ensure that our supply and our exhaust systems are meeting the minimum air exchange requirements for the areas within the practice where it's particularly relevant and where there's a risk. So the just a little bit about air changes. How we calculate that is we determine the height and the length and the width of a room in meters, and we calculate the volume of the room. So that's the height times the length times the width. And then we determine the volumetric flow rate. And you can usually get that from your HVAC system operating manual, or airflow testing can be conducted as well. And from that, we can then calculate what are the air changes per hour within the designated rooms. So sometimes it's better to get a ventilation professional in, as I said, you know, an HVAC engineer or an occupational environmental hygienist to help you do it. Now, if we look at higher risk rooms, so risks where we're likely to have to apply airborne precautions for patients who are suspected or are confirmed to have a respiratory virus, for example, or we're performing AGPs, then it should be at least 12 air changes rather per hour. In dirty utility rooms, we talked about last week. So in our reprocessing area where we're conducting our manual and or our automated cleaning, there should be at least 10 air changes per hour. That's really important to do that. Now, if we're not able to meet those requirements, then we might need to be looking at how we can augment or supplement that. And we've talked about the addition of air purifiers or air cleaners if your risk assessment indicated your ventilation system wasn't adequate. We also have to remember that our ventilation systems do require routine maintenance, and that includes your filter cleaning and or your changing. So if you are using an air purifier or air scrubber, air cleaner, then that requires maintenance on the filters as well. I've just put 2 references down there. These are references that I find very useful from the Australian Commission on Safety and Quality in Healthcare. You will receive this presentation afterwards. You'll be able to click on the links and access those. And also the Vic Health has actually put out some very good ventilation guidelines online that I found really easy to read and also to be able to apply the principles there. You remember we talked about last week making sure that in our reprocessing and our storage areas that our ventilation system, we're working towards complying with AS 5369, and that's about airflows from clean to dirty. And I gave you some tips, the sheet on the right-hand side, particularly where in a lot of practices we co-locate these clean and dirty reprocessing activities, and what are some of the strategies that we can actually put into play to reduce the risk of environmental contamination and personnel contamination as well. So let's move straight into aerosol generating procedures. So it moves on quite nicely. So what are AGPs? So aerosol generating procedures are those procedures that stimulate coughing and promote the generation of aerosols, resulting in the risk of airborne transmission. So these might include nebulizer therapy, the use of high flow nasal oxygen, continuous positive airway pressure therapy or CPAP, also bi-level positive airway pressure, so BiPAP therapy, sputum induction, open airway suctioning, lung function testing such as spirometry and peak flow measurement, and also tracheostomy management and cardiopulmonary resuscitation. So we have to sort of do a little bit of a risk assessment again. So everything's that risk-based approach and applying our quality insurance to actually determine, do we undertake AGPs within our practice? And if we do, what procedures are they? And what is the relevant risk? And then how do we actually mitigate that risk? So I find this is quite helpful. I only just found this nice little, I suppose it's an infographic really, that just describes to us what actually happens with aerosol generation. So if we have a look, normally we have our tidal breathing, and that in itself produces respiratory particles. And that's based on the interface where with the airways, we put some stress on the mucus and the air interface, and then that leads to the formation of aerosols and droplets. So down here in the bronchioles, we tend to see aerosols being produced, and then up in the upper respiratory tract, we see more the droplets. So then when we add coughing and sneezing, in addition to just the normal breathing, so expiring air out, that actually increases the general high flow rates. So that in itself, coughing or sneezing, then produces even smaller respiratory particles. And then when we look at the environment and what actually happens in the environment, now hopefully if we've got a good ventilation system, we've got lots of good, clean, fresh air coming in, and then we've got it being removed out into outside of the building. But what can actually interfere there can be just simply human activity. Too many people within the environment, their movement can actually create these vortexes that carry the respiratory particles in their wake. And we can therefore get further transmission, and why sometimes in chickenpox outbreaks, the source can be in one room, and then through airborne transmission, we can have subsequent non-immune patients in other rooms actually acquiring the infection. I found that the little table below is actually also really interesting when we look at what are some of those aerosol generating procedures and the maximum distance that these particles can actually travel. So if we look up the top here, a non-rebreathing oxygen mask, the particles actually don't go that far. But as we go further down, we can start seeing that when we get to nebulizers, and there's even a difference between a person with a normal lung having a nebulizer and those with severe lung injury or lung disease, down to our non-invasive intubation, such as our BPAP and our CPAP, and how much further those particles can actually be exhaled, therefore increasing the risk for transmission of infection. So it's not an easy subject, and probably why there's been, I suppose, at first, I think when COVID happened, we were all very aware, lots of rulings came out about not performing AGPs, and maybe that was a little bit exaggerated. So we have to sort of take into context all of these principles of aerosol generation when we're, I suppose, putting our risk mitigation strategies into place. So some of the transmission factors, activities with forced exhalation, so we've talked about that, the symptoms and disease burden, so a symptomatic person versus an asymptomatic person, the distance, so we know that the respiratory particles are going to be most dense closest to the source, so within that 1 metre. So, it helps when we're looking at those strategies for mitigating the risk. The duration of contact, so the longer exposure to the pathogen, to those, virus-laden droplets or aerosols, then higher the risk. So we've always sort of talked about that 15 minutes being the threshold. Our ventilation, so if we've got a closed environment and we've got very low levels of ventilation or even low levels of ventilation, then that increases the risk of transmission. And also fomites. Now, we've probably focused a lot on fomites, but they're probably not as significant. It's more about the airborne and the droplet transmission that we need to be concerned about. Okay, so what are some of the risk mitigation strategies? So firstly, undertake that risk assessment. What is the risk of virus or bacterial transmission while we're performing AGPs, and how can we reduce that? So we always go to our hierarchy of controls. We want to eliminate the risk, but that's not always going to be possible. Some people do have to have their medication administered via nebulizer, for example. People do need BiPAP, they do need CPAP. So if we can't eliminate, can we substitute the risk? Can we isolate the risk? Can we use engineering control so we can engineer the hazard or the risk out of the procedure? Can we use our administrative controls? And as we know, the lowest and the least effective, our PPE controls. But what we actually finish up doing is usually a combination of these strategies to be able to manage the situation. The Thoracic Society of Australia and New Zealand and the Australian New Zealand Society of Respiratory Science put out their position statement in 2022, right at I suppose the height of the COVID pandemic. And both of those organised professional bodies' recommendations reflected a precautionary approach. Rather than saying, no, we don't do it, then let's risk assess and put in the appropriate strategies. Because we're wanting to protect the safety and health of all patients, as well as the healthcare workers. And these have been supplemented with state and territory infection prevention and control guidelines or directives, which I've referred to. So elimination is about screening all of our patients. And we've talked about that, particularly in webinar 1 in the series. So, if the person, do they have a suspected or is it confirmed that they have an infectious acute respiratory infection? Are there new respiratory symptoms present? Have they had any exposure or epidemiological risk factors? Is the procedure clinically indicated at the present time? If we're doing pulmonary function testing, then, if we have a patient who we suspect or we confirm has an ARI, can we actually delay that testing if it's clinically indicated? Or can we refer them on to someone? We do want to try and avoid nebulization unless there's no other alternative. So as I said, some patients have to have their therapy to be effective. It needs to be delivered by aerosolized medication. We can look at substitution and modification. So we're moving down the hierarchy of controls. So we can make this to the test circuits that we use for our respiratory therapies or the procedures, so that we're actually trying to reduce the number of aerosols that are being generated and therefore reduce the transmission at risk as well. So we can reduce the type of tests to the minimum required, particularly when we have high levels of community transmission, or again, if we're in the midst of a pandemic with either an existing organism or perhaps a novel or emerging respiratory virus. The administration of a bronchodilator medication via the metered dose inhaler and a spacer rather than a nebulizer if possible. The use of the breath-actuated nebulizers. This is versus a standard continuous small volume nebulizer. So what these do is increases the drug efficiency, and that's associated with a decrease in the release of aerosols to the atmosphere. The only problem is it comes at a cost in terms of treatment time. So it's about 2 to 3-fold over a standard unit dose. And we can also look at non-vented mouthpieces with filters on the exhalation ports. So that actually prevents the escape or the release of gas through exhaled air. So again, it's just minimising the risk down. We can look at disposable mouthpieces containing those one-way valves to prevent inspiration through the equipment and therefore minimise the risk of contamination. If we look at isolation, we've talked about some of these already. Telehealth supervised home spirometry can be done. We can create physical barriers between the operator and the patient. So maybe transparent screens, just being aware that the barrier size and the placement may interfere with air movement and the ventilation systems. There's not too much evidence to support that. Staying out of the blast zone or the line of cough. Ensuring that AGPs are performed as a single patient per clinic room, having a designated clinic room that we know has got adequate ventilation. We can produce those air changes per hour, physical distancing, and also, density limits. So minimising the number of people in the room, the operator and the patient, and maybe a carer if that was indicated. And keeping it closed to other internal spaces within your building as well. We've talked about inline antibacterial and antiviral filters, particularly over the course of the pandemic. These have really become standard practice now, and they can be placed at the proximal or the distal end, so between the circuit and the patient. Surgical masks for our patients who are having during their field walking tests, and also just, normal good respiratory hygiene and cough etiquette, and encouraging that in our patients, but certainly in our clients, in our staff as well. So anything that is reusable, of course, anything if we're using an inline filter or any added-on device to try and minimise the risk, it doesn't actually eliminate the need for cleaning and disinfection of any reusable equipment that we may well use. And engineering control. So that we talked about a ventilation assessment is a really good place to start if you haven't already done, making sure that we're performing these AGPs in a well-ventilated single room, achieving the minimum 12 room air exchanges per hour. If we can't do that, then if you've got windows, open up the windows. You may well have to augment your ventilation system by using an air scrubber if the risk assessment indicated. So it's really important that the air in the room is being exhausted to the outside, and if it is, that it's away from any air intake vents, so we don't have that contaminated air coming back in, that it's away from people and animals. So we need to be looking outside of our buildings as well, and what's actually happening. We had talked about these HEPA filtration systems to supplement or augment the room ventilation, and really important that after we've carried out an AGP, that we leave that room unoccupied for at least 30 minutes. And that will really depend on what you are able to achieve with those air exchanges. If you do have to re-enter the room in that 30-minute period of time, then it's full respiratory protection. So our airborne precautions are really important. So this just shows you the air changes per hour and the time required for the airborne contaminant to be efficiently and effectively removed. So if we're looking at 99% efficiency, as we go down the number of air changes, we can see that the time changes. So if you're sitting at about 6, which is a standard room air change, then it's going to be 46 minutes to achieve 99% removal efficiency. If it's 99.9% efficiency you want to achieve, then it's going to take longer, 69 minutes. So that's a long time if you're a busy practice and you're doing a number of AGPs in a list. As we come down, so what we need to be achieving for AGPs is this 12, okay? So if we're wanting to achieve 99% efficiency removal, 23 minutes. But if we're wanting to achieve the maximum as much as we can, so 99.9, then that's that minimum 35 minutes. So I find this is quite helpful as a guide for you. Our administrative controls, so this is about decluttering, minimising furniture, equipment and other fomites in areas where or rooms, designated rooms where you're performing your AGPs, routinely cleaning and disinfecting our high-touch surfaces and any non-critical equipment that comes into contact with your patient, and remembering we're using TGA-approved disinfectants and for the required contact time, whether that be 1 minute, 2 minutes, some of them are as long as 10 minutes. We're reprocessing any semi-critical or critical reusable medical devices that have been used for that particular procedure, and that's carried out in conjunction with the manufacturer's instructions for use. If the manufacturer says that it's a single-use item that can be reused, then you need to follow those instructions strictly. We can use single-use items such as sensors and mouthpieces, nose clips and spacers, and these should not be reprocessed for multiple uses unless it's stated it is reusable. If we're using single-use items, we need to dispose of them into the appropriate waste stream so we don't have any risk of transmission of the environment. And you can always request your patient to bring their own short-acting bronchodilator, inhaler and spacer for use during the testing, or use the single patient use MDIs. So there's a number of administrative controls, and we can see more around waiting times, screening and diagnostic testing, education, training and competency assessment of our staff, around donning and doffing PPE, airborne precautions, how to perform spirometry in a safe way, applying infection prevention and control principles, making sure our equipment's calibrated and certified, having policies and procedures around your AGPs, having staff not attending work when they're unwell themselves, and following any state or territory jurisdictional guidelines or directives that may come out from time to time regarding this issue, particularly in times of increased community transmission of respiratory viruses, but also during epidemics and pandemics, and encouraging our patients to be up to date with their vaccination status for some of these vaccine preventable respiratory diseases, and also staff as well. Our PPE controls, still effective, but sort of least effective on the hierarchy of controls. So applying our PPE controls in relation to droplet or airborne precautions, depending on if the patient does have an ARI, although we are trying to avoid doing the testing in that instance, making sure that if we're wearing P2 or N95 particulate filter respirators, that the staff have been fit tested and they fit check every donning application. And of course, our hand hygiene. And where possible, offer your patient surgical masks if they're undergoing those functional exercise assessments. So there's a whole load of mitigation strategies that we can put into place to ensure that we are performing aerosol generating procedures in the best interest of the patient, but also in the best interest of the staff, and that we are minimising the transmission of these. So let's now focus on environmental cleaning, and we can whiz through this because we have alluded to some of it in the last two. You should all be aware of the IPC guidelines, where you're required to have a current cleaning policy that identifies staff responsibilities, any work health and safety issues, and the procedures for routine scheduled cleaning, unscheduled cleaning, and the monitoring of the effectiveness of that cleaning as well. And again, that you take a risk-based approach to this so that you can determine the methods and the frequency and the thoroughness of the cleaning, and also the products and the equipment to be used. And so all staff need to understand that, you know, they have a responsibility in relation to cleaning. The primary and community healthcare standards, which apply to services that deliver healthcare in the primary and or the community setting, also have their item on clean and safe environment under their preventing and controlling infection clinical safety standard. So again, they're requiring a process to be in place so that you can maintain a clean, safe and hygienic environment. And it's about being able to respond to environmental risks, including novel and emerging infections as well, using products that are listed on the Australian Register of Therapeutic Goods and using those products with consistence to the manufacturer's instructions for use, and ensuring that staff who clean, and I would, you know, look at your contractors as well, that people have had adequate education and training and maybe competency assessment if that's indicated for routine cleaning, but also in those outbreak situations. And as I said, when we have those novel and emerging pathogens arising. So if we just look at the background, we know that the practice environment is a potential reservoir of organisms. It is clearly linked to the chain of transmission. So we need to take that risk-based approach and identify and manage those organisms. It is part of standard precautions, and it needs to be applied at all times to all patients or consumers in all healthcare settings. So your cleaning program needs to be implemented within the framework of your IPC program. It's not a standalone intervention. It's actually multifaceted, because it's not just about the actual cleaning or cleaning and disinfection of the environment, but it brings into play the leadership, support, education, training, monitoring, and also feedback systems. You know, people need to know that they're doing well, or if there's an area for improvement. So I quite like this model from the Centres of Disease Control that looks at, you know, organisational governance. It looks at policies and procedures to support the cleaning program, staff training, making sure that you've got the appropriate infrastructure and the supplies to be able to implement the cleaning strategy, and then providing that monitoring, feedback and auditing to evaluate that your cleaning program is effective, but also efficient as well. So if we look at environmental transmission, I quite like this little diagram from the CDC, so that we can see that if we have a colonised or an infected patient, we can have them contaminating environmental surfaces or non-critical equipment within your practice environment. We then have the hands of the healthcare workers or other personnel or visitors actually coming into contact with these contaminated surfaces, and they're transmitting it on to other susceptible hosts. Or we can have these susceptible patients coming into contact with these contaminated surfaces and non-critical equipment from the previous colonised or infected person. We do know that some of these healthcare-associated pathogens can survive on environmental surfaces for varying periods of time. You know, it might be hours through to days and through to months. The survival times do vary, and that's because there's a whole load of environmental factors involved, and that might be around temperature, relative humidity, but also even the surface type can actually interfere with that. So we've got lots of evidence now, and it continues to increase. In fact, I was on a webinar earlier in the week, international webinar, where we had experts from the UK actually talking about environmental cleaning and disinfection and the relevance of both. So there's lots of things to consider on a routine basis, but also through outbreak and pandemic control as well. So as I keep alluding to, we take a risk-based approach. So we really need to be thinking about the number and the type of microorganisms present on environmental surfaces within your practice, the number of people within the environment, the amount of activity that goes on within that environment, the amount of moisture, because we know all of these contribute to transmission of infection, the presence of material that's actually capable of supporting microbial growth, the rate at which organisms are suspended in the air are actually removed from that environment, and the type of surfaces and orientation. So, a horizontal surface versus a vertical surface. So your risk assessment will actually determine your cleaning method, the process, the frequency, and the products used for both your routine cleaning, but for any enhanced or contingency cleaning schedules for your practice areas. I do like the PDAC model. So this is the Canadian model, where they categorise the risk factors to determine the need for environmental cleaning, and that's around the probability of contamination with pathogens. So you have to think about your practice environment. Is that likely to be heavy, moderate, or light? Think about the vulnerability of the population that you service to infection. So are they more susceptible, or are they less susceptible? And what is the risk of potential for exposure? So, your high touch surfaces versus your low touch surfaces throughout your practice. That then allows you to determine what the total risk is, and you can, risk score it using your risk matrix that we talked about in last week's webinar. So is it low risk, moderate risk, or high risk? And then determine your cleaning frequency based on that risk stratification matrix. I've just put a couple of slides. I'm not going to dwell on them in relation to key terms and definitions. So we really can define what environmental cleaning is, surfaces, non-critical patient equipment, and your patient care areas. And then also delineate between cleaning, disinfection, and sterilisation. So, this is the level of asepsis that we go to. So cleaning is about physically removing the soil and the dirt and the organisms through detergent and water, or maybe a combined detergent and disinfectant product. Disinfection, we're trying to inactivate the non-sporing organisms. That might be through hot water disinfection, so thermal disinfection, or by chemical means. And as we talked about last week, sterilisation, where we're trying to completely destroy or remove all organisms. Now, that's not possible. To sterilise our environment, any healthcare environment, we can't sterilise. That's really around reusable medical devices. So our cleaning method and process. So again, quite a good table here to actually assist you to determine your cleaning method and process from the Australian Infection Control Guidelines. So when we look at cleaning, we're looking at our routine cleaning, our non-critical patient care equipment. So, they tend to be high-touch items. They're used by healthcare workers to touch patients. They're frequently touched by healthcare workers and patients, and they're often shared between patients. We need to consider your enhanced cleaning and disinfection. So that might be single patient management, where you're having to apply transmission-based precautions. It might be an outbreak situation or pandemic. We need to consider scheduled cleaning, your terminal or your discharge cleaning, so that patient who's been on airborne precautions or contact precautions while they've been in your practice then leaves. So how do we clean their environment after they've left? Unscheduled blood and body fluid spills management, which I'm not going to talk about this evening in the interest of time, but we did talk about it in webinar 1. So when we look at our routine environmental cleaning, you can split it up into those surfaces that are minimally touched and those that are frequently touched. And there's some examples there. And then it just gives you some sort of guidance in what the cleaning requirements may be based on those, the frequency of touching those surfaces there. If we then, once we've worked that out, we can ask ourselves the question, is there likely to be a multi-drug resistant organism or other infectious agent requiring transmission-based precautions? The answer is no. Then using a detergent solution would be quite sufficient in the practice environment. If the answer is yes, or you're not sure, then, again, we're looking at our setting. In our acute care settings now, we routinely clean with a detergent solution combined with or followed by a disinfectant. They're high-risk healthcare settings. Lots of people, lots of healthcare workers, lots of patients, often very invasive procedures. They're often very sick, susceptible patients. In the non-acute setting, you can consider a detergent solution combined with or followed by a disinfectant. Your risk assessment will help you guide your cleaning strategy, therefore your method and your process. I popped in a slide around best cleaning practices. So ideally, we want to be able to work in a systematic way. So, you know, this is whether you have staff within, designated staff within your practice who clean, or whether you use your contract cleaners. If you use contract cleaners, you want to be ensuring all of this is happening and you're monitoring. So if we work in a systematic way within a room, it might be left to right, it might be clockwise, or it might be anti-clockwise. We want to clean from dirt. We want to clean from clean to dirty, so that we're minimising the risk of cross-contamination. We want to clean from high to low or top to bottom, clean in an S-shaped pattern. And we'll talk more about that shortly in relation to wipes. And we want to ensure that if we're using a disinfectant, that we're using it for the correct contact time. So your product evaluation is really important. One of the first questions I ask is, what is the contact time? In order for this disinfectant to be effective, how long does it have to remain wet on that surface? It's got to remain 10 minutes. To me, that's not practical. No. Now we have products on the market, it's a 1 minute contact time. So far more practical, far more efficient in a busy practice setting. And this is what I refer to as the S shape. So a lot of the companies, particularly those who produce wipes, will provide manufacturers instructions in relation to this. But what you can actually see is by using this method, we're actually not recontaminating and we're not transferring bugs from the surface back onto the surface that we've actually just cleaned. Cleaning frequency, again, it's justified by the risk of transmission of infection within your practice. You may find that you require more frequent, rigorous cleaning with a different method or a different process in areas of high risk. So that might be a designated room where you do see patients who require transmission-based precautions, or it might be in your designated room where you perform your aerosol-generating procedures. We know that our frequently touched surfaces are going to be cleaned more frequently, at least daily, certainly when they're visibly soiled, and after every known contamination by a likely pathogen. Those that are subject to less frequent contact, they'll be cleaned less frequently. So always to remember to be flexible in your cleaning schedules. We need to be able to adjust our schedules based on the presence of an infectious agent. And that might be, as I said, a single case. It might be a community outbreak within your locality, or it might in fact be a pandemic, as we have experienced. So developing your cleaning schedule, some of the things that we need to consider, some of the factors when developing that schedule based on your risk assessment is around your governance structure, roles and responsibilities, any legal requirements, accreditation requirements, your policies and procedures, the type of services that you provided by your practice, human resources, you know, who's going to do the cleaning, the cleaning resources themselves, the building design. You know, sometimes it's harder to clean older buildings that have porous surfaces, non-intact surfaces. Consider the local epidemiology, what's happening within your community in terms of transmission of infection cases as well. Really important. And we've just popped up an example of a documented cleaning schedule. So you should have these documented cleaning schedules, which actually outlines who's responsible for the cleaning, the area or the location within the practice, the surface that needs to be cleaned, the cleaning method and the process, and the products to be used, and the frequency of that cleaning as well. I've put a couple of tips in there in relation to that, but around product equipment selection, it's really going to be around your process. So consider the PPE that you use for cleaning, because what we're trying to do is prevent exposure to microorganisms, prevent exposure to chemicals, and also the spread of microorganisms from one patient to another within the practice. And there are lots of different options that sometimes makes your product and equipment selection a little tricky when you're reviewing it. So we have our microfiber systems versus, you know, our conventional cotton, our flat mop pads versus our conventional cotton loop mops. Do we use launderable versus disposable? So you may launder in accordance with AS416, the Laundry Practice Australian Standard. Other practices may use disposal. Some practices may use a combination of normal, routine cleaning. We use launderable cleaning cloths, launderable flat mop heads, but when we have an outbreak or an increase in community transmission of a particular infection, we move to disposable. Do you use a charging bucket versus a conventional bucket system? Do you two-step clean, or do you do a two-in-one clean? Think about maybe two-step clean is actually more efficacious, but is it practical? Is it time efficient? They're the sorts of things we have to think about when we do our risk assessment. Solution versus wipes, and we really do need to think about our cleaning and our disinfectant agents. And remember, it's a TGA listed hospital grade agent that we should be using. So I've popped in a slide on how to choose the right disinfectant. So the things that we've got to consider when we're looking at disinfectants is the bug characteristics. So their ability to survive for prolonged periods of time on environmental surfaces, their ability to remain virulent after exposure to the environment. Are they at concentrations that are sufficient to result in transmission? What's their ability to frequently contaminate the healthcare environment surfaces? The ability to colonize patients, the ability to transiently colonize, your own hands. Do they just require a small inoculating dose to cause transmission? And what's their relative resistance to environmental disinfectants as well? So if you're looking at reviewing, if you are using disinfectants within your practice and you're looking at reviewing them, then, these are the sorts of questions that you should consider asking, particularly of the manufacturers, the distributors, or the suppliers of those products. What are the kill claims based on those bug characteristics I just actually talked about? Now, traditionally, a disinfectant was considered most likely to achieve disinfection if it was applied to a clean surface. But now, except when we were having to manage blood contamination spillages, but now there's a generally accepted adage was to clean always before infection. But with some of the novel products that are on the market now, the impregnated wipes and also the solutions, they contain both a surfactant and also a disinfectant. So meaning that, these processes can be actually performed simultaneously. So when you're looking at choosing your disinfectants, think about the wet contact time that I talked about. Think about the compatibility of the product to the surface. Think about the safety issues for staff, but also patients, the ease of use, how practical is it to use this product, and are you getting value for money as well, which, is very important with our budget. We talk about, if we're using disinfectants, we talk about low-level, intermediate, and high-level disinfection. In the environment, we don't do high-level disinfection. These are automated processes, e.g. a washer disinfector or an endoscope reprocessor that we would use on critical and non-critical reusable medical devices. So in the environment, we look at low-level or intermediate-level disinfectants, depending on the pathogens that we're likely to see and the pathogens that may contaminate our environment, and we want to either kill or inactivate. So some of the types of low and intermediate level disinfectants include the quaternary ammonium compounds, the ethyl or isopropyl alcohols, the chlorine releasing agents, and also the improved hydrogen peroxide products. So there's quite a lot there to consider. In relation to pre-saturated wipes, they're becoming very commonly used, and they do contain surfactants, but also disinfectants and wetness. So it's really important that we choose a pre-saturated wipe correctly, and we ensure that it's got sufficient of those three to, in actual fact, be an effective process, and that we can actually use them for the stated contact time. Excuse me. We want to know from the manufacturers, the suppliers, or the distributors that the disinfectant can actually achieve disinfection given the microbial and also the soil challenge, so the dirt that's maybe, or the body substance, the organic matter that might be on that surface. We want to be able to use the wipe in a systematic way, as I alluded to before, so that it removes that gross soiling, and then it's able to clean and disinfect the entire surface. So you may find that you do actually have to use 2 wipes. If you were using a wipe system and the surface was very dirty, you would use 1 wipe to clean, and then you would use 1 wipe to disinfect. And always think about the size of the wipe as well. A 13 by 10 centimetre wipe can't really be expected to disinfect an entire, for instance, mattress and bed rails of a patient examination bed or trolley. So we do need to consider that, most certainly. But ask, what is the efficacy of cleaning and disinfection of any pre-moistened wipe that you might be using that requires it really requires both the disinfectant to be tested as well as the delivery method. And you can ask for the suspension test and also the surface test. There's some very good papers around how to choose pre-saturated wipes because you need to be assured that you're going to achieve the benefit that you want to achieve within your clinical setting. Minimal time requirements to prepare, to perform, and to remove any residue and waste associated with the use of these pre-saturated wipes. Now, excellent paper that was done by Edwards and colleagues, which I've provided there for you. Actually, what they did is they studied how the surface is to be wiped, the type of fibre within the wipe, and how the presence of a liquid biocide or a disinfectant affected the degree of recontamination. And they did experiments on a number of surfaces, metal, ceramic, and also plastic healthcare surfaces. And they used 2 different wipe compositions with and without a liquid biocide. And what they found is that despite initially the high removal efficiencies, in fact, it was greater than 70% during the initial wiping, all the healthcare surfaces were recontaminated with E. coli, Staph aureus, Enterococcus faecalis, when it was wiped more than once using the same wipe. So recontamination does occur regardless of the fibre composition of the wipe or the presence of a disinfectant. So it really comes down to making sure that we know how to use the wipe correctly. So refer to the manufacturer's instructions. And out of this paper, this piece of research, they came out with this ditty: 1 wipe, 1 surface, 1 direction, and dispose. So many of the manufacturers of these wipes have actually taken on that research and they provide, we talk about the S-shaped pattern or the Z-shaped pattern. So we're not recontaminating an area that we've already cleaned. Think about material compatibility. It's one of the questions that you ask when you're choosing your detergent and or disinfectant products. Think about, is the surface cleanable? Is it easy to maintain or repair? Is it resistant to microbial growth? Is it a non-porous surface? And is it seamless? Because if we have some of these deficiencies, then it's going to be really difficult to actually be able to clean that surface. There are some emerging cleaning technologies, and I will leave you to be able to review this yourselves, but we talked already about ultraviolet irradiation. When we talked about ventilation systems, we can also talk about this in relation to environmental surfaces. There are fogging or misting machines. There's high-intensity narrow spectrum lights, and there's also steam vapor. Probably the steam vapor is becoming quite popular, but they all have advantages and disadvantages, these methods. So if you are considering emerging cleaning technologies, again, there's some questions that you have to think about for your practice and organisation. Does your practice actually need to use an emerging cleaning technology? Would your practice actually use this technology? How would you use it? Does it meet the current recommendations for environmental cleaning? So we refer to the Australian Infection Control Guidelines, the Clinical Excellence Commission in New South Wales, the Australian Commission on Safety and Quality in Health as well. Can you meet the manufacturer's instructions for use as well? And taking into account the safety and health of your staff, but also perhaps your contractors as well. And last but not least, we come full cycle with our cleaning strategy. We really do need to have methods for evaluating environmental cleanliness. And again, there are advantages and disadvantages to these methods. Best practice, performing standardized assessments is really about looking at the cleaning work practices of your staff, but contractors if you have those, and also the level of cleanliness. Doing our direct observation. So, looking at the effectiveness of the cleaning. So watching people's performance, visual assessment of the cleanliness. Again, that's direct observation. So, we can check our items cleaned. We can use fluorescent markers, much like we do for our hand hygiene techniques. We can also use this for our environmental cleaning techniques. ATP bioluminescence has been used in the food industry for a long time. We can now apply this to environmental surfaces in healthcare, other environmental surfaces in healthcare facilities. And that's really just detecting, have we removed the organic material? So it's a really good way of evaluating whether the cleaning process is and method is effective. And we can also do environmental cultures as well. So this is really looking at what is the microbial load or contamination on that surface actually after cleaning. Probably not something we do routinely, but if you have an ongoing problem that's been identified, then it may be valuable in that instance. So what we've been talking about is using that risk-based approach, but also implementing the hierarchies of controls from elimination through to PPE. And we can do it through all areas that we've just talked about: ventilation, cleaning, and also our aerosol-generating procedures. So it's a really good model that underpins your infection prevention and control program and the measures within your program. So in summary, the healthcare environment does play a role in the transmission of healthcare-associated infections, and we do have research to support that. So the areas that we've talked about tonight are fundamental interventions of your infection prevention and control program. They're part of standard precautions, and they're also part of transmission-based precautions where we need to implement that. In order to be effective, then we need to implement these measures within the framework of your IPC program. It's not a standalone intervention, as I said before. It sits along other key program elements, and that's around governance, administrative controls such as education and training, your policy and procedure development, your monitoring, and also feeding back to the practice staff as well. I've got a couple of slides there of the references that I've used this evening, and also there's some references on some of the slides throughout the presentation as well. So hopefully this will assist you to support your existing practice and maybe to enhance any future practices or measures that you would like to put into place.